Dr. Ghada Alkinishi, Professor of Internal Medicine in the Biology Unit. Today we will discuss three, although rare but important subjects. We will discuss congenital adrenal hyperplasia, gynecomastia, and hirsutism. First, we will start with congenital adrenal hyperplasia. As we all know from your previous study that we have that the adrenal medulla is formed of two parts, the adrenal cortex and the adrenal gland, is formed of the cortex and the medulla. The adrenal medulla is the part concerned with secretion of adrenaline and noradrenaline, while we have in the adrenal cortex we have three zones. Yes. Zona glomerulosa for aldosterone, then fasciculata for the secretion of corticosteroids, glucocorticoids, and the last one is the zona reticularis responsible for the secretion of sex hormones. So what is congenital adrenal hyperplasia? It is an inherited disease. Not one disease, it is an inherited group of disorders due to deficiency of one enzyme necessary for cortisol synthesis. So it is more than one syndrome. We have many congenital adrenal hyperplasia syndrome. It is inherited in an autosomal recessive. This is why it runs in certain families, and in certain races it is more common in Jews. So the genetic background is different from deletion point mutation. This will result in different enzyme dysfunction and different degree of enzyme deficiency, which will result finally in different phenotype. Phenotype means the appearance or the clinical configuration due to this genetic defect. So we have, due to this different and wide range of genetic disorders and wide range of enzymatic deficiency, we will have wide range also of clinical spectrum, ranging from mild form to severe form. The severe form usually present in the neonatal period and usually is associated with soul twisting. Soul twisting here is due to association of corticosteroid and aldosterone deficiency. This is the severest form. We have another more mild form, which is known as late onset or non-classical congenital adrenal hyperplasia, which may present in adulthood after puberty. This diagram demonstrates how cholesterol is transformed through many steps into three final end products, into aldosterone, cortisol, and testosterone. All the three products come from cholesterol. So if we have an enzymatic defect in this pathway, this will result in decrease the synthesis of cortisol and divert the formation to another step, as we will see later. So congenital adrenal hyperplasia, it is an enzymatic defect in cortisol synthesis. We have many enzyme deficiency which can result in congenital adrenal hyperplasia. We have 21 hydroxylase enzyme deficiency, 11 beta hydroxylase, 17 A hydroxylase, 3 B hydroxylase, but the commonest one is the 21 hydroxylase deficiency. What is 21 hydroxylase enzyme? Hydroxylase enzyme 21 hydroxylase result in reduction of the hormone end product, which is the cortisol. Low cortisol level will lead to increased feedback mechanism, result in increase of STH and will produce hyperplasia. So the name congenital adrenal hyperplasia results from cortisol deficiency, feedback elevation of STH, and increase the size of the adrenal, resulting in hyperplasia. As we mentioned, the clinical picture will reflect the effect of inadequate production of cortisol and aldosterone and increased production of androgen. So, when we have the commonest form, which is the 21-hydroxylase deficiency, cholesterol will transfer to progesterone and then stop, and to 17-hydroxyprogesterone, there will be no cortisol synthesis, no or partial deficiency on the cortisol, depending on the degree of 21-hydroxylase deficiency. This will result in some way in negative feedback of increasing STH and directing the formation towards the only available pathway, which is the formation of androgen. So finally, we have 17-hydroxyprogesterone and adrenal androgen as the final and the function, the only working established function of the adrenal cortex in case of a congenital adrenal hyperplasia. So, 21-hydroxylase is the commonest enzyme deficiency. This is the only one we will discuss in our lecture. Accounts for 90% of the affected individuals with congenital adrenal hyperplasia. This enzyme is responsible for hydroxylation of progesterone and 17-hydroxyprogesterone into cortisol. 75% of the affected infant will have aldosterone deficiency in combination. This is known as the salt wasting type, and 1/4 of the patient affected with the deficiency of 21-hydroxylase or the 21-hydroxylase subtype of congenital adrenal hyperplasia will have just virilization. So about 3/4 is associated with salt wasting and 1/4 is associated with virilization. What is the clinical presentation of cortisol deficiency, aldosterone deficiency, and androgen excess? This will depend on the degree of enzyme deficiency, and so the time of presentation will also depend on this variation in the enzymatic deficiency. If we have a grave and a significant decrease in 21-hydroxylase, so there will be marvelous increase in the androgen, even can be detected clinically at birth. At birth, congenital adrenal hyperplasia due to 21-hydroxylase deficiency can manifest only in female fetus, or female newborn, not in male. So in female, we have a syndrome or a clinical characteristic picture known as female pseudohermaphrodism or ambiguous genitalia. So, although she is a female, she will have the external genitalia which looks like a male. She has a big clitoris, she has fused labia which can resemble a scrotum, small vagina, the vagina may be hidden by the fused labia. As it is a grade 4 and present at birth, so there is usually in about 3/4 of the patients there is salt wasting due to aldosterone deficiency. So, at birth, congenital adrenal hyperplasia present in female with big clitoris, fused labia. There is the milder form, we have more grave form, so it appears as if she is a male. Even this girl, she can grow up as a male for 10 years, 12 years, and then when puberty starts, they discover that she is not a male, she is a female, which means so she will need, besides her genital reconstruction, she will have to be treated psychologically for this differentiation in her sex. So this change in her sex. Male, because male is the one who usually have androgen, so the normal genitalia appears normal at birth. If this male is unfortunately affected with salt wasting type, he can present after birth with acute illness, vomiting, diarrhea, dehydration, polyuria, collapse, hyponatremia, and hyperkalemia due to aldosterone deficiency. If we have less severe form of 21-hydroxylase enzyme, the patient will present postnatal. In this case, the presentation can occur in male and in female. In male, he will present with precocious puberty. He will reach adulthood, he will reach his puberty earlier than his colleagues. With masculinization, with manifestation of androgen, masculinization, deepening of voice, body hair, male distribution of body hair, but this patient will be shorter, he will have a stunted growth, and this is not a true puberty because LHF and FSH are not elevated. This is not his normal surge of puberty, so there will be no spermatogenesis. The testis may be of infantile size and there is no spermatogenesis, and the patient will suffer from stunted growth. As you know, that sex hormone affects the final height. This is in male. In female, if she presents postnatal, so she will present with virilization. This term we will discuss later. She will have male-like distribution of hair, hirsutism. She may suffer from primary amenorrhea, lack of her breast development, and also stunted growth. So this is the manifestation in male and female if the presentation is more milder and appears during childhood before the age of puberty. And after puberty, we have the non-classical type, which is rare to be associated with salt wasting. It is also known as late onset congenital adrenal hyperplasia. It affects girls, not boys. Present in later childhood or early adulthood with hirsutism, acute menstrual irregularities, and maybe infertility. So the presentation differs according to the genetic background, the degree of enzymatic deficiency. In severe form, we have manifestation in female baby, and in milder, the most mild form, we will have presentation in girls as well, but post-pubertal. So what is the investigation? I think that we can all know the investigation from the pathogenesis and the final biochemical hormonal, the expected final biochemical hormonal profile. So this patient will have increase in the 17-hydroxyprogesterone, which is the step before 21-hydroxylase enzyme, which needs 21-hydroxylase enzyme to be converted to cortisol. 17-hydroxyprogesterone, like any other corticosteroid preparation or corticosteroid product, it should be measured at 9 a.m. because of the circadian rhythm due to associated surge of STH in the morning. Besides increase in the 17-hydroxyprogesterone, we will have decrease in cortisol and aldosterone. Basal STH is increased as a result of feedback mechanism. Androgen, testosterone, and androstenedione level will be in the adult male in a female. So if we have a female with an adult pattern of adult level of testosterone, this is highly suspicious of congenital adrenal hyperplasia. Besides this manifestation, because this is very important, because in some mild case, we may have cortisol and aldosterone normal level. So this does not exclude congenital adrenal hyperplasia. We have to measure testosterone. What is the treatment? The treatment is to cut down this feedback mechanism. If we give the patient steroid, if we give him cortisone, prednisolone in 5 to 7.5 grams per day, divided in 2 doses, the biggest dose will be at night, so 1/23 of the dose will be given at night, while 1/3 in the morning. This helps when we give the largest dose, the biggest dose at night. This helps to suppress the morning surge of STH. So the main treatment is with corticosteroid, with steroids. If the patient is having salt deficiency as well, we can give him, in addition, or we can give her, because this is usually a disease of female, a salt retaining product, mineralocorticoid, which is a fludrocortisone. Anti-androgen use is restricted in female, not in male. It is used for hair hirsutism. We have many anti-androgen preparations. This will be discussed later in hirsutism, but we should not give the patient spironolactone, because spironolactone has a potential risk. It lacks aldactone. It has a potential risk of aggravation of salt wasting. So the main therapy is steroid, mineralocorticoid, anti-androgen in female with acne and hirsutism. Avoid spironolactone. Adrenalectomy may be the last line of treatment if the patient has severe paralyzation and she is resistant to conventional treatment. So surgical removal of the adrenal can be done in resistant cases with severe virilization. I think this is the last slide for congenital adrenal hyperplasia. It is one of the difficult subjects in endocrinology, but I think I give you the simplest form. So if you have any question for congenital adrenal hyperplasia? Second, okay. The second subject today is hirsutism. What is hirsutism? Before knowing the definition of hirsutism, what are the types of hair we have in our body? We have 3 types of hair. We have, any question? Okay, can you hear me?
Yes.
Okay, so we have 3 types of hair in our body. We have lanugo hair, we have vellus hair, and finally we have terminal hair. Lanugo hair is the fetal hair. Some fetus, some newborn, some babies may have hair even covering their whole body. This is a fine hair which is of no importance. It is known as lanugo hair. We have in the prepubertal area period, we have short, fine, unpigmented hair known as vellus hair. After puberty, we have the terminal hair, which is coarse, long, pigmented. It arises from the vellus hair. So we have 3 types of hair in our body. We have 3 sides of hair. Our hair is classified into non-sexual hair and bisexual hair. This means that present in both sexes, in male and female, and male sexual, which is a male characteristic hair. Non-sexual hair is present in the eyebrows, lashes, forearm, lower leg. We all have this type of hair. So lower leg and forearm hair is not asexual or a male pattern of hair. And bisexual in the skull, we have the temporal and vertical part of the skull covered with hair for male and female. The axilla, the lower pubic hair, is not a sexual hair. Male sexual, which depend on androgen, in its formation or its transformation from vellus to terminal hair. Hair in the ear, in the nasal tip, in the chin, in the sternum, in the upper pubic triangle, in the back, and in other sides we will discuss later. This is known as male hair, male pattern of hair or sexual hair. So hirsutism is an excessive growth of terminal hair in androgen-dependent area. Androgen-dependent area which are the male sexual area. This in the upper lip, in the chin, in the sideburn, in the ear loops, in the tip of the nose, in the back, chest, lower abdomen, and anterior side. And this is what we mean by hirsutism. So hirsutism is an excessive growth of what type of hair? Of vellus hair, of terminal hair, in what side? In androgen dependent area, which means a male pattern distribution of hair. So this is hirsutism. What is virilization? Virilization is more than hirsutism. Virilization means that a female is going to be like a male, not just in hair but in other body characteristics. So when a female is going to lose her feminizing characteristics, this is known at first. She will take two steps. The first step is defeminization, and the second is masculinization. So virilization is composed of defeminization and masculinization. Defeminization, what characterized female, will be lost. So there will be atrophy of the breast, vagina, irregular menses, and finally amenorrhea. Masculinization, she will have hirsute, a deepening of her voice, temporal balding, increasing size of clitoris, muscle mass increase, and increase of libido. So we now agree that we know the definition of hirsutism, which is excess secretion of terminal hair in androgen-dependent area, and it is one of the components of virilization, which includes other more wide spectrum of clinical characteristics. So my second question is, from where is adrenal produced in female? So female have androgen and male have androgen. لسه قايلينها دلوقتي تمام كده صحيح. احنا لسه قايلين we have just mentioned that one of the causes of congenital adrenal hyperplasia is overproduction of androgen from the adrenal cortex. So the source of androgen in a female is from the ovaries and the adrenal. So the ovaries produce androgen. We have different types of androgens. The most famous is testosterone, but the adrenal have a unique type of androgen just secreted by it. So dihydroepiandrosterone is secreted by the adrenal. It is an androgen secreted by the adrenal. While testosterone and its precursor, androstenedione, is equally secreted from the adrenal and the ovaries. So as the adrenal secrete 50% of androstenedione and the ovaries 50%. 50% of testosterone is secreted by the 25% of testosterone is secreted by the ovary and 25% by the adrenal. Androstenedione is converted peripherally into testosterone. So androgen production in a female is equal from both adrenal and ovaries as when we talk about androstenedione and testosterone, but the adrenal have its unique testosterone or androgen hormone, which is dihydroepiandrosterone. at the level of the follicle will be converted to the active form, which is the dihydrotestosterone, by an enzyme known as 5-alpha reductase. Testosterone in a female has two ways of consumption. Either in the hair follicle by the use of 5-alpha reductase to produce dihydrotestosterone, which is responsible for the transformation of vellus into terminal hair, or it is transformed into estradiol by the aromatase enzyme. This is another way. So, can you tell me what are the causes of hirsutism? استوعبته يعني congenital adrenal hyperplasia. So we may have either increase for hirsutism to occur in a female. We may have either increase in the androgen, so the absolute level of androgens is increased, or increase in the sensitivity of the androgen receptors at the level of the hair follicle. And the third cause, it may be caused by increasing the activity of 5-alpha reductase. I think this is wise. This can match what we just discussed. So these are the three main causes of hirsutism. When we translate this into causes, we have the source of androgen, the adrenal, and the ovaries. So some disease in the ovaries, some disease in the adrenal can produce hirsutism. If a female is taking external source iatrogenic intake of testosterone or androgen-like drugs. If we have a decrease in the sex hormone binding globulin, because this is very important. The biologically active hormone is the free part of the hormone. If we have a decrease in the sex hormone binding globulin, so we'll have increase in the free testosterone, which can lead to hirsutism. So the causes of, the pathological causes of hirsutism is one of four: either adrenal, ovarian, external, or decrease in the sex hormone binding globulin. The commonest ovarian and the commonest cause of hirsutism is PCO, polycystic ovary. It is the commonest endocrinological disease in a female. Many females have ranging from mild degrees to severe form of PCO. So it is the PCO, polycystic ovary, is the commonest form. It accounts for 95% of the cases of hirsutism. We may have in the ovaries, we have androgen secreting tumor or hyperplasia of the ovarian stroma resulting in excess secretion of androgen. As regards the adrenal, the commonest is congenital adrenal hyperplasia. You are professors now in congenital adrenal hyperplasia. We have androgen secreting tumors. You take Cushing syndrome. Cushing can be associated with androgen manifestation, with acne, and with hirsutism. Intake of anabolic steroids, of testosterone, of danazole, which is an anti-androgen, which is used in endometriosis, can cause. Testosterone can be given in breast cancer, for example, in hormonal sensitive tumors. Some females may take testosterone as a therapy. So treatment with anabolic steroid, with danazole, with testosterone, with many other drugs can cause some degree of hirsutism. Hyperinsulinemia, insulin resistance result in decrease in the sex hormone binding globulin and increasing free testosterone and appearance of manifestation of hyperandrogenemia. Liver disease, you know that estrogen is mainly catabolized in the liver. Acromegaly, prolactinoma, and hypothyroidism are also associated with decreased sex hormone binding globulin. All these diseases are associated with decreased sex hormone binding globulin and increase in the free testosterone. So this is the four items, the four main pathological disease which can lead to hirsutism. But in some cases we have hirsutism without an underlying cause. This is known as idiopathic. We have two types. We have idiopathic hirsutism and familiar hirsutism. Familiar hirsutism means that we have more than one member in the family, the girl, her aunt, her mother, and her grandmother. So we have more than one member with hirsutism. So this is their hair. This is this family hair pattern of hair pattern hair distribution. It has an ethnic background. So in Mediterranean, for example, there is a higher incidence of having familial hirsutism than other ethnic groups. In this familial hirsutism, the patient genetically or ethnically is having a higher density of hair follicle per area of the skin. So the number of follicles are increasing per area of the skin. Idiopathic hirsutism means that there is no family history, but we have no underlying pathological cause. After exclusion of the 4 causes of hirsutism, we found no cause for hirsutism. This is known as idiopathic hirsutism. It is believed to be due to increased activity of 5 reductase enzyme or increasing sensitivity of the hair follicle to androgen. So we have the pathological causes of hirsutism, and we have 2 benign or physiological causes of hirsutism, familial and idiopathic. Familial and idiopathic hirsutism usually have the onset of hirsutism after puberty, and it is slowly progressive. The female is usually having her normal menses and normal fertility, and the most important that we exclude abnormalities in her hormonal profile. So to say that this patient is idiopathic or familial, she has to have a normal hormonal profile. How can we evaluate a case of hirsutism? First, we have to confirm the diagnosis. Is it right a hirsutism, or is it just the patient is overestimating her hair pattern? So we have to confirm the diagnosis. We have to determine the degree of hirsute and exclude the grave condition, especially the androgen secreting tumors. The onset of the disease, the progression, and the duration will make difference. So if we have a rapid progressive virilization post-pubertal, this is inconsistent with androgen secreting tumors. Menstrual history is very important for diagnosis of PCO, which is usually associated with irregular menses. Pregnancy is important in the history because many drugs are contraindicated during pregnancy. The family history of her female of the females in her family, the drug intake syndromes like Cushing, prolactinoma, hypothyroidism, pathological diseases can be excluded by history and examination. Examination, in a general examination, we will look for obesity, thyroid disease, Cushing, sign of virilization, signs of insulin resistance, which decrease the sex hormone binding globulin like acanthosis nigricans. We look for galactorrhea because prolactinoma and hyperprolactinemia is associated with increased adrenal androgen and hirsutism. Pelvic examination for the presence of masses, tumors, adrenal or ovarian palpable masses. When we assess the degree of hirsutism, we will assess it in these 9 areas using some scoring system. This scoring system divides the hair distribution in each of this area into minimal, mild, moderate, and severe. To diagnose hirsutism, the score of this patient must exceed 8. So we have hair distribution ranging from mild, moderate, more severe, and severe form with the degree 4. If we have more than 8, this diagnoses hirsutism. What are the investigations? The most important investigation is to measure the testosterone, the total and free testosterone, which indicates that there is ovarian or adrenal hypersecretion of androgen. Then we will measure 17-hydroxyprogesterone, which points to congenital adrenal hyperplasia. Dihydroepiandrosterone is a good marker of adrenal production because it is produced by the adrenal cortex. It is very important also investigation to investigate for BCO. BCO we can investigate, we can measure LH and FSH. We do pelvic ultrasound for detection of any of BCO, of cysts in the ovaries, or for ovarian or adrenal masses. What is the treatment of hirsutism? We have general measures, specific measures, and local measures. General measures, this is very important in familial or idiopathic hirsutism to assure your patient and to discuss the condition with her, and lastly to inform her that the treatment of hirsutism is a time requiring. It will not disappear in days or months. Stop smoking. Weight reduction, because when weight is reduced, the free testosterone will decrease due to increase in the sex hormone binding globulin. What are the specific measures used for the treatment of hirsutism? Oral contraceptives are the main drug used, besides spironolactone, which is aldactone, which is an anti-androgen. This is the two commonest drug used nowadays for the management of hirsutism. We have other drugs which can produce ovarian suppression, like GnRH, progesterone, and other anti-androgen like cyproterone acetate. We have a combination of cyproterone acetate and oral contraceptive, which is used frequently in the management of hirsutism. We have other drugs like flutamide. We have alpha-5 alpha reductase inhibitor like finasteride. Insulin sensitizers like metformin will reduce weight and will improve the sex hormone binding globulin and decrease free testosterone. So these are specific measures for the management of hirsutism. We have local measures. This differs according to the female preference, according to her, what she thinks is better for her. But we have now some maneuvers used for permanent removal like laser and pulsed light. This cream is not present in Egypt. It acts by reduction of 5-alpha reductase. This as regards hirsutism. The last subject is gynecomastia. So to be fair, one for male and one for female. So we have the disease of female and we have to listen to the disease of male. So hirsutism is a disease of female and gynecomastia is the presence of breast tissue in a male. 25% of the cases is due to unknown causes. 10 to 25% of the cases is produced by medication. We have sometimes we have pubertal gynecomastia. This is a physiological condition in a boy. When reaching puberty, about 50% of boys may have gynecomastia, usually asymptomatic, and this will disappear spontaneously in less than 1.5 years. In 18 months, this gynecomastia will disappear. In old age, we are usually afraid of serious underlying diseases like cancer of the breast. Also, breast cancer is common in female. It is a disease of female but can occur in male. And other serious underlying conditions like bronchogenic carcinoma and testicular tumor. So care in old men is with gynecomastia is required to exclude this life-threatening condition. What are the causes of gynecomastia? We have have some physiological causes, like in some units, in some male babies may be born with gynecomastia and even galactorrhea. This is known as witch's milk. It may be due to the estrogen transformed through the placenta of his mother. Pubertal gynecomastia we just discussed in the previous slide. In aging male, may be due to serious condition, but in old age, 70s and 80s, you know that we have andropause in male, we have menopause in female, and we have andropause in male. So a normal male may have, during his aging process, when he is old age, he may have physiological gynecomastia, but exclusion of the serious condition should be the work up of the physician. Liver. هو في نقطة هنا. البريست في two components as regard the breast, or two different hormonal medium. Milk formation and milk ejection depends on prolactin. This can occur pathologically in male and in female. So we have hyperprolactinemia, which can be presented in male with impotence, with infertility, and even rarely, very rarely with galactorrhea. In female, the same. She may present with hirsutism, she may present with infertility, she may present with galactorrhea in non-nursing female. And we have the breast tissue itself. The main component for the breast to develop, for the breast tissue to develop, is estrogen, not prolactin. Besides other hormones like thyroxine, for example, thyroxine is an important hormone for the formation of the acini, but not for the milk formation. Milk is by the prolactin, and prolactin is under inhibitory during normal life. Is under inhibitory suppression from the hypothalamus. So other diseases like hyperthyroidism may result in gynecomastia. Liver cell failure, although it is not mentioned in these causes, but liver cell failure is one of the main causes, and even you will not see gynecomastia during your student life except in patients with liver cell failure. And in your clinical rounds, the doctor will mention that this gynecomastia may be due to the disease itself, as liver cell failure will result in increasing estrogen, or it may be due to drugs, spironolactone and lactone, which is one of the first line of therapy for ascites, for hepatic ascites. So liver cell failure, hyperthyroidism, estrogen-producing tumors in the adrenal or the testis, human chorionic producing tumors in the testis or the lung, bronchogenic carcinoma. Carcinoma of the breast should be excluded, especially in old male. Starvation refeeding, this in severe starvation, if we have like in Somal or in Central Africa, for example, if they are starved with marked weight loss, with marked protein calorie malnutrition, and then if they are refeeded, this can lead to gynecomastia. One of the commonest causes is drug-induced gynecomastia. So if a male is accidentally taking an estrogen, digitalis have an estrogenic-like effect, anti-androgen like spironolactone and lactone, cimetidine. We have many other drugs which can lead to gynecomastia. This is the last slide. So signs and symptoms of gynecomastia may be unilateral or bilateral, may be tender or painless. One of the important things in diagnosing gynecomastia clinically is the presence of breast tissue. Breast tissue circumannular around the areola. This is completely different from a mass, a hard mass, which is present in one side. Also, we have to differentiate between gynecomastia and lipomastia. If we have a male, an obese male, some fat may deposit in the breast and produce lipomastia, not gynecomastia. Patient with the gynecomastia should be diagnosed for exclusion of the causes of the cause of gynecomastia, and we can do mammogram or even ultrasound on the breast to exclude cancer breast and so on. And thank you.